well, most of you already know who I am, and I've worked with a lot of you throughout the past 4 years, or I guess 5 years now. My title, Adapting Class Recommendations in Healthcare for Hispanic Populations. Just a little bit of background about the North Carolina Academy of Family Physicians. For those of you who don't know, we have, we're just a specialty organization representing family physicians throughout the state. We have about 2,700 members, and those make up practicing physicians, residents, medical students, and retirees. And we are actually the only medical specialty group that's represented in all 100 counties in North Carolina. So it makes us pretty unique. Now you saw in my title about adapting class recommendations. So most of you are like, well, what is class? And here I'm going to tell you a little bit of background information about that. Class is something I work with on a day-to-day basis, so I know really well, but I know a lot of you don't know too much about it. But these are the culturally and linguistically appropriate service standards, and it's what we use at the NCAFP as our guidelines for educating physicians and helping them implement these in their practice. We use them because they were developed by the National Office of Minority Health, and so we think they did a pretty good job doing it. Not to mention that 4 of them are actually federally mandated, so it's another good reason to use them. There's 14 standards, and it really just serves as a common definitions, common understanding, so that we can all come together in the healthcare profession and use the same set of rules. They're also divided into 3 groups: culturally competent care, language access services, and organizational supports. And there's a lot of words on here, but I know you guys were getting handouts, so I want to make sure you had it all. But I'll go through each one pretty quickly just so you can kind of get an idea of what exactly these are. It's a lot to understand. I have to explain these to physicians and nurses and receptionists, and it takes a long time for them to really get a good handle on what these are. It took me a long time too, so I understand. Under culturally competent care, we have respectful care compatible with cultural health beliefs. And I think this is kind of just sums up all 14 standards and just says you're going to provide care that's respectful to the patient and the language that they need, and and the kind of care that they want to receive. Staff recruitment says that you're going to recruit, retain a diverse staff of representing your patient population and also the community. Standard 3, ongoing education and training, and this just says that you're going to provide training to your staff and even have it mandated, whether it's annually or however you do it. And these are the 4. The language access standards are the standards that are federally mandated, which I learned throughout the years that even though these are federally mandated, most practicing physicians have not even heard of these standards yet. So as you can imagine, a lot of them aren't implementing them as they should be. But Standard 4 just says that you're going to provide service in the language that the patient prefers. Standard 5 says that you're going to let patients know that they have a right to receive language or services in the language that they need. Standard 6 says that you're going to make sure that your language services are competent. Standard 7 says that you'll have signage and health materials in the languages of your patients. Are you getting bored? Yeah, I know. We still have 2 more pages of these. Organizational supports. That you're going to write into your strategic plan different goals related to the class standards. Number 9, organizational self-assessment is just saying that you're going to constantly, on an ongoing basis, do either patient satisfaction surveys or some form of evaluation to make sure that you're doing a good job. Standard 10, information as part of a medical record, means that you're going to collect race, ethnicity, and language data from your patients. Standard 11, maintain demographic profile of the community. And this one's important because a lot of times your patient community does not match the community locally where you're serving, and those 2 should match. 3 more. Develop collaborative community partnerships. This means having community input in what you're doing in your practice and participating in health fairs and different community events. 13, culturally sensitive conflict resolution, kind of speaks for itself. 14 is letting the community know that you are doing these things, and really giving yourself a pat on the back and letting the community be aware of the things that you're doing. A little background on our Phase 1 and Phase 2 HDI grants. Began in 2006, as you all know. Our key goals were really just to increase knowledge and awareness for physicians of health disparities and different cultural differences for disease states through education, and also identifying successful models for using the class standards in an intensive practice-based intervention. So the problem, as we've talked about a lot today, a lot of the things that came up are already in here. Lack of cultural competency, which I'm constantly addressing, can lead to negative health outcomes for a lot of the things that we've mentioned. Lack of knowledge. Physicians' lack of knowledge that certain disease states are more prevalent in certain populations. Fear. Patients not accessing care because they're scared. How many times did we say that today? Patients not adhering to advice because they don't trust or even understand the physician. We mentioned that today too. Another important thing is that healthcare providers in North Carolina are caring for a population much different than their own. There are only 6% of providers in North Carolina that are African American, and I believe 2 that are Hispanic Latino, 2% Hispanic Latino. And it's important to note that some medical students or some medical schools today, not all of them yet, but are implementing a cultural competency training for their medical students. But that leaves all these physicians that are already out there practicing not receiving any kind of education. So that's where my job comes in. So I work with these physicians on a day-to-day basis, and I said, hey, for this project, I'm going to focus on people that I don't work with really at all, or see on a day-to-day basis, and I'm going to focus on Hispanic adults. And so what I decided to do was, like my title said, adapt the class standards to the Hispanic community. So I decided to do focus groups, and I really tried to make it as hard as possible on myself. I don't speak Spanish, I'm not Latino or Hispanic, and so I did these focus groups. I did 2 in Alamance County, 1 in Wake County so far. I'm going to do 1 more in Wake County. They're about an hour and a half in length, and I asked them questions specifically related to the class main themes: the culturally competent care, language access, and organizational supports. It's important to note that I did have an interpreter and a bilingual co-facilitator, so it's kind of a little spectacle, but it was a lot of fun. Lessons learned started before I even conducted the focus groups, as I'm sure happens with a lot of you guys. You must be personally tied into the Latino community, which we've learned and learned and learned, and especially at NCCU, we learned about CVPR, and I knew all that, but I thought, hey, I can do this, I can be the person to do this. And I figured, I know enough people that work in the Latino community, but that doesn't mean I do. And so, I had my mentor, Rosa, and I had a couple other people that I knew that I could go to help recruit people, and it still didn't work. We didn't have people coming to these focus groups. We even had them at places I thought that they would, maybe even go to on a regular basis. But we still didn't have the numbers coming that we wanted to. And so this definitely went through a lot of frustration. But and I was surprised that handing out flyers and posting flyers from places, we did get some people. So I guess that was a good thing. But also, one of the key lessons I learned, and it was another thing that I already knew, but I made the key mistake when using an interpreter. And that is that I was sitting there with Rosa, my mentor, who speaks Spanish, and one of the participants. And I turned to Rosa and I said, can you tell her blah, blah, blah? And Rosa looked at me, she goes, will you tell her? And I was like, oh my gosh, I can't believe I just did that. You're always supposed to talk to the participant. And so, I sat there, and then afterwards I went in my car, I was like, oh my gosh, I was like really beating myself up about it. But how many times do we do that when we even know something? And so I was thinking about my physicians that I work with, and how many times they're even, they don't want to mess up like that. They don't want to do these things, but they do on a regular basis. And then maybe after that, then they're too intimidated and they don't want to, go through that again with their Latino patients. So we haven't even gotten to the focus groups yet, but all that happened. Before the focus groups, well, when the participants first came in, I handed out a survey, and these are the results of that. It was a mix of male and female. The age range 24 to 56, which I thought was a pretty good range. They were from Mexico, Peru, and Puerto Rico. They had lived in the United States for anywhere from 1 to 30 years. And most said that they did have health insurance, and one person said that they had health insurance in Mexico. So I'm not sure how many people actually had health insurance in the US or if they still had it back home. And most people said that they had a doctor that they went to. We didn't really elaborate on what that meant because a lot of people took their kids to the doctor and went to a pediatrician. So that might have been why they said yes to that. But you know, half did say that they'd been to a doctor in the last year. This is it's a work in progress, but these are the main themes that I've learned so far during the focus groups, and I did break them down into the class themes. For culturally competent care, overall they just wanted a good doctor. They didn't care if the doctor spoke Spanish or not. As long as the doctor was a good doctor, built a relationship with them, cared about them, and respected them as a person. Well, I think that's what all of us want. But it was just really interesting to me that they said that it doesn't matter if the doctor speaks Spanish or not. It's just a good doctor. Language access services. They really liked it when the doctor tried to speak Spanish, even if it was just 1 or 2 words. And this was another eye-opener for me because, you know, I took Spanish in high school like most of you did, and I know words, and there would be times I'd be sitting there where it's on the tip of my tongue, I'm like, no, I don't want to look stupid. Well, you know, and then after I heard this, I was like, oh, you know, throwing out words every now and then. And they do, they love it, and then I felt more connected to them too, and I was like, how did I not realize this before? But again, you know, and I can just imagine our physicians, they don't want to look stupid either in the patient room. But knowing that, I mean, if you just throw out 1 or 2 words that you know, or just, you know, you can really build a relationship with that patient. And also, it's key to note that they did have, almost all of them had bad experiences with interpreters, and this kind of made me sad. But all of them would rather have a family member or a friend come and translate for them than the interpreters. There was one experience where a woman was going in and she was walking in with the interpreter, and the interpreter is on the phone with her boyfriend and holding up the doctor. So then the patient and the interpreter get in the room, and the physician's mad at the patient, thinking that the patient was holding them up. And so it's just things like that, which I guess will require a lot more interpreter training to be more respectful and to really appreciate the gift that they have and that they're giving to these patients. Also, a lot of them, they just work too much. They don't have time to see the physician. If they don't have a specific disease that they know of, they're not going to do it. And especially because when they're not working, the clinics aren't open. And so a way to address this is just, you know, building awareness and education of clinics that are open, because in most areas now there are clinics that are either open on nights or weekends that they could go to. And still many went back to their home countries for health care, which is just sad when, you know, a lot of times access can be an issue, but where these people were, they have a clinic or a hospital at least pretty nearby to them, and yet they went to Mexico. In the future, I will be conducting at least 1 more focus group. I wish I had more time. I wish this was a 3-year program, because it seems like I learned a lot through mistakes this 2nd year, and I could have used another year to do more focus groups. But I am definitely using this information to educate our providers and our physicians through our magazine and our website. And actually last night I did a presentation to our NC Health Disparities Advisory Group, and it went really well with them. And so just building awareness and letting people know about the findings that I had, and letting physicians know it's okay to make mistakes, but go ahead and put yourself out there and really be willing to build a relationship with the patients. And that's it. Big thank you to Rosa and Carla, who are my co-facilitator and my interpreter. They're not here today, unfortunately, but I could not do it without them for sure. But But that's it. My contact information's here if you have any questions, but if you have any questions now, I think I can answer them, right?
Yeah, we do have a few minutes for questions after each presentation, so yeah, absolutely. Please go ahead.
Just curious, great presentation.
Thank you.
I'm curious about the interpreter issue though, because the class standards would indicate that you have to have a competent interpreter, which would tell you not to allow a family member or someone without a health background to do the interpreting. But if you're trying to be respectful, what are the thoughts there?
And that's why I really think it needs to be a more comprehensive interpreter training. I know that there is no one interpreter kind of, what do you call it, evaluation or type of thing yet, but I know it's being worked on. But a lot of the patients were just saying, you know, and some of them spoke a little bit of English, but they were using the interpreter because the hospital or whatever said that they needed to. And they could hear that the interpreter wasn't translating the information correctly. And so it's really discouraging when we're telling them, you know, you can't use a family member, use an interpreter, but then the interpreters aren't communicating correctly. So hopefully that was just, you know, this select area. But you know, once there's a broad-based evaluation or training, I think that will help a lot. And I will mention too that a lot of times in clinics, the interpreters aren't actually a full-time interpreter. They're, you know, the receptionist or something else, and so they're not wanting to do that on top of what they're already doing. And so I think that's another problem too, is that, you know, if it was a perfect world, like we were mentioning in our group in the earlier session, you know, we would have money for that, to be able to have interpreters in everybody's clinics, you know, 100%, and that would definitely help out a lot. That's a good question.
Now, out of the 3 focus groups, how many people did you end up talking with? And then for the things that you learned from the focus groups, well, no, you said they did a survey. Is that a written?
Yeah, that was a written survey that was both in English and Spanish, and Rosa actually went through it with them, because at first we handed it to them, and then we're like, okay, no, this isn't going to work. So Rosa went through each question with them and really explained what they meant. And she did the same with the consent form, too.
But the survey was more demographic, was it not?
Yeah. Exactly.
How many people was it?
Okay, overall, let's see, in the first one I had 6, which I was pretty happy about, and there were 5 males in that group, so that was great. The next 2 were more like one-on-one interviews, unfortunately. And so it was really, really frustrating, but that's, again, why I wish I could do more, and we're going to do at least 1 more. But I do feel like I got a good broad base of people, even in just that little group. So yeah, so definitely more needs to be done.
Thanks, Jenny.
Thank you.
I was sitting there thinking, you know, well, I have to come up with a joke, because you have to incorporate humor somehow or another. So I thought about yesterday, we had dinner at Olivia's. Is anybody familiar with the restaurant? Olivia's? Okay, good.
Genesis.
We got this restaurant and we eat and everything, and we had to go to the bathroom, Valerie and I. So Valerie said, well, pay good attention to the walls and the people that's on the walls. So, you know, I was looking around, but really had to use the bathroom, so really didn't pay much attention until I relieved myself. So, so it was John McCain on the wall, it was, you know, Johnny Cochran on the wall, and it was John F. Kennedy, and a few other Johns. She was like, so what do you think they all have in common? I was like, I know they're still living, and some of them are anyway. And I said, so it couldn't be death or anything like that. So I said, well, I don't know. She said, well, their names all began with John. I said, okay, whatever. Of course, but you're in the John. That was pretty funny. So that's my humor. So if you guys didn't laugh, then. So yes, I'm Crystal Dempsey, and I am the regional coordinator coordinator for Northeast and Buncombe County Partnership for Health related to health disparities. And we at first were serving 18 counties, but now we have downgraded to 15. We had a district that pulled out of the project. So now I'm serving 15 counties in the East. And everybody's familiar with where the Northeast is, very rural area. So we were flooded really bad with the weather. We're recuperating. I put this slide here to illustrate, kind of to give a concept of how this Eastern Health Network came about. Every year we have a leadership conference in the East, and we talk about disparity issues. And one of the things that we wanted to do this past time was really get something out of this conference so that, you know, we can build up on, so that we can kind of, you know, bring more resources and, you know, empower our communities and to kind of get more out of the conference this year, or this past year. So I put this up here to illustrate, this is where this concept came from. Our Unity in Communities Creating Healthy Opportunities Leadership Conference. Some of the feedback that we got from some of the conference participants, we had 4 different sessions. We had sessions dealing with political issues, a session dealing with schools, sessions dealing with community-based organizations, as well as faith-based organizations. So we felt like that we had those 4 different sessions that we kind of accomplished everybody in the community to kind of get information to build up on what we were trying to accomplish in the East. So this is some of the feedback we got from the participants. They wanted more resources in the East. They wanted to be more self-sufficient. They wanted to learn how to advocate both locally and at the state level. They wanted more growth in the area. They wanted to develop more shared resources, to collaborate more. They want good, honest leaders. And they wanted to see less territorial issues, because in the East, you know, there's some turf issues there. And they wanted to see their people more empowered to take more initiative in their own health. Okay. Here, this particular slide shows the problems that we face in the East. And the previous slide also showed, you know, some of these problems as well. And these are some of the concepts that we had come up with. And they're kind of similar to what the people in the community was sharing with us as well. Okay. And we all just kind of build up on that. And my mentor, Liz Lynn, she helped me come up with this concept here. We understood that we had a lot of health disparity issues. And we had provided a lot of programs to kind of try to alleviate some of those disparity issues. But they still exist. So we had to kind of dig a little deeper to figure out, you know, what are some other disparity issues that we need to kind of focus on to help eliminate this down here. So we knew we had a lack of structural disparities. We had a lack of infrastructure, capacity building, collaboration, resource development. Also, we had a lack of resource sharing, community support, and community engagement. Then it trickled down to our personal disparities, which included a lack of employment, education was low, environmental housing issues, as well as healthcare issues, which trickled down to health disparities. And that's when we saw an increase of heart disease, stroke, HIV disease, diabetes, hypertension, and cancer. So we were saying, you know, it starts here, so if we can kind of focus on trying to increase or get some positiveness here, then when we get down to here, we can see a decrease in some of these health disparity issues. So we came up with the Eastern Health Network concept, and the Eastern Health Network will create avenues to strengthen communities via capacity and infrastructure building and sharing resources across county lines to eliminate health disparities in the eastern region of North Carolina. The network will be piloted in 5 counties initially in the Northeast, which will be Bertie, Burford, Edgecombe, Hereford, and Northampton, and gradually roll out to the remaining partnership counties. So we're going to pilot in 5 counties first, and then we'll kind of incorporate the rest of the counties into the network. New developments. As we were kind of meeting and getting ideas about this network, what we really wanted to see, kind of focusing on the feedback that we got from the conference and and from the community, because we know that we needed to have community engagement and information from them in order to make it work. So we knew that the Office of Minority Health was going to be offering funds for, that they offer their grant funding cycle. So we thought that we would apply to them to receive funding to help us with this particular project. And we got the funding for it. We also knew, and we wrote in the grant, that we were going to do 5 focus groups. So we knew we had to get IRB approval. So we submitted that information. And we had key informant conversations with leaders in the community to make sure that they were on board with what we were trying to do. So we had conversations with them, and got feedback from them as well. And we were able to bring on new partners and build new relationships in the community. Some of the challenges. We had a major change in the timeline because, and I say that because we had to do an original timeline for the project. But once we got funded, our timeline changed. So we had to deal with those particular issues. We had my supervisor resigned, and she was a major player because she was going to be focusing on the political issues of getting the network started. So that left that burden on me, but we have to do. And health department partners developed amnesia. What I meant by that is our partnership is actually made up of these health departments. And one of the things that they had agreed to do, and they've always agreed to do this, was give me a disparity gap coordinator 10% of their time. So at the last, well, not just at this particular meeting, they were asking a whole lot of questions as to, all of a sudden, why do you need these gap coordinators? What are they going to be used for? And remind you that they actually did sign a letter of agreement in the grant that they would provide that staff time for me, because I can't do it by myself. So they forgot that. So I had to actually literally pull the grant, which I made copies of, pull the grant and show them the letter of commitment that they actually signed their name. So, they had a dull look on their face. But that's okay, So, and then, as many of you know, when you're going through a particular project like this, you have a lot of people who say that they're committed, but they're really not, and they're really not focused. So you have a lot of players that's not as committed to the project as you are. So you have to come up with interesting strategies and ways to get them more involved and committed to the project. Then again, we have our turf issues as well, still going on, so we have to work through that, and the IRB process, since you all probably know about that. And some next steps, and this is the second button I have broken today. So I'm just going to leave my code open. Today, and oh well. But our next steps, this is what we plan to have happen in the future, is we're going to conduct the focus groups, and hopefully all of them will be done by June 2011. Analyze that data that we get from the focus group, and that information that we get, we're going to actually use it to create our plan for this network or this collaboration. So we're going to analyze that data hopefully by August 2011. Then we're going to begin our strategic planning activities by October 2011 as well. Again, through that process, we're going to use the data that we get from the focus groups and also from the key informant interviews that we've done. We're going to develop the Eastern Health Network plan, hopefully and this probably will be just a rough draft plan, by 2010. We're going to reveal the plan at the leadership conference, which we have every year, but this time we're going to actually do it biannually instead of annually. So by the time the conference comes around, we should have all that information and at least a rough draft plan ready to reveal to participants. And by 2012, we're going to actually implement the plan. So hopefully we'll have everything together by then. This is the plan. And I put this slide here, which is a reverse of the original slide that I showed you earlier. So we said once this network is actually implemented and put in place and running like it should, our structural disparities, we're seeing increase in some cognitiveness with infrastructure, building capacity, collaboration, resource development, all those things we will see happening. Personal disparities as well. We'll see improvement in employment, education, environmental and healthcare issues, and then we're also seeing a decrease in health disparities such as heart disease, stroke, HIV disease, diabetes, hypertension, and cancer as a result of the network. Y'all have any questions about the joke?
I didn't go to
You mentioned in your presentation the first 5 counties. Are you just working with the 5 counties now, or have you branched out to the other ones?
No, we're just working with the first 5 counties now.
Okay.
And once those counties, we've, gotten all the information from them, and actually they are part of the network, then we're gradually pulling one additional county at a time to get what we need.
Are there opportunities for our programs to work with you?
Oh, absolutely. We're always looking for new partners.
Okay.
Have all the gap coordinators been identified at this point?
Yes, well, they've been in place, like I said, for a long time already. It's just that the health departments just forgot that, the health directors. So we've been working with them for a long time anyway.
Okay,
They
there
have
are
been,
people who are existing employees.
Mhm.
Who has ownership of the network in terms of makeup or structure of the network?
partnership.
Because there's a partnership with those 5 counties, but who comes to the table to represent the network? Does the health directors, the mayor, those kinds of individuals?
Well, we're pulling, as I mentioned before, we had 4 sections in the leadership conference. We had the political realm, the school, the community-based organizations, and faith-based organizations. So what we did was we pulled leaders from each one of those categories to actually make up who's going to actually run or take leadership, if you will, over the network. No questions about that?
Dr. Pence told you earlier that we all start our projects real big and we have to narrow down. I really began on Save the World. I ended up with this. And I felt despair many times. But this was interesting because dealing with substance abuse, particularly with the Hispanic population, it's a two-pronged approach. Because there were people that were all willing to speak with me, and there were others that really had nothing to say to me. When I was talking about substance abuse, they'd say, well, they don't need to be here, they need to go back. And then I went to one major Hispanic group and said, can we talk a little bit about Hispanic substance abuse? They said, no, we need to be talking about immigration. That doesn't work. So I didn't get a lot of buy-in from some folks that I really thought I would. But that's okay. And which button do I press?
Space bar.
The space button.
Space bar.
Cool. Just real quick, because I know we're very short on time. Here's some quick stats statewide. 250,000 people, 12 years and older. Over 500,000 report alcohol dependence. That's a lot of people in the state of North Carolina. For a state that has 9 million and change. That's an awful lot of people that report dependence or involvement with substance abuse. The interesting part is, and this is my absolute favorite one, look at the difference in 2 years. It jumped up from 4,400 to 21,000. That's pretty amazing. And that doesn't include a whole lot of Hispanics, which historically don't report. Access to health care with Hispanics is very difficult. Now, my colleague Jenny spoke earlier about the family medical centers and the family practice and such working on it, but that's only a small number. There's a great many practices that really aren't set up for Hispanics, don't really want that population, and I got a lot of that population when I was dealing with this. They just don't want to deal with it because they don't have insurance, they don't have Medicaid, they have to bring in a translator and so forth. So that was a little bit of a disparity, and that's just dealing with just health issues without even getting into substance abuse. Jenny mentioned that some of them had personal doctors, actually had doctors they were comfortable with, but she was right in the fact that in many events, that actually is the pediatrician. They take the child to the doctor, they consider that their doctor, but that's not really their doctor. And this is the main one right here, the fear of legal issues. And many times the legal issues, for example, if a person is working, and there's a lot of Hispanics that work construction, they get hurt on the job, they won't go to the emergency room. They'll go to somebody that the family knows who maybe was a doctor, or said he was a doctor, or worked in a hospital, or something, and that's the way they get their treatment. Most interventions are geared towards the user. This is where I get into the actual substance abuse part. The interventions that try to deal with substance abuse, many interventions are geared towards the user. But the user, if you're familiar with substance abuse at all, it's based on denial. It's, he doesn't have a problem, she doesn't have a problem, they don't need treatment, they don't need help, they're fine. It's no different with the Hispanic culture. It's a little bit more exacerbated in the Hispanic culture because historically, the man is out working every day, he's working, he's bringing home money, and even if he drinks a lot on the weekends, the family is somewhat okay with that. They're not going to really push it, and that creates problems. And the only time you hear from it is when some Hispanic is driving down the road, gets a DUI, and kills somebody. Then it's all over the newspapers. But as far as that person trying to get some help, and the curious part is many times they focus a lot on he's had several DUIs, he's got speeding tickets, everybody knew he was drinking. Why didn't someone do an intervention? But that's not what they look at. There is a movement, the SAMHSA, the Substance Abuse Mental Health Service Administration, is now putting out the SBRID, which is a document or a screening format that's going to go in primary care centers, hospital emergency rooms, and so forth. But again, that is geared towards the user. It's not geared towards the family members. And Hispanic substance abusers usually don't use traditional methods for health care. Fear of authorities, back again. Where I tried to do with my project was not do what everyone else did, not deal with the user per se, but to shift the paradigm and try and target the family members. That's the best part of this, trying to deal with the family members, because the family members, particularly the mothers and the sisters that actually do use healthcare facilities, they're in a good position to see the information, if it's right in front of them, to try and make a little bit of decision making on their part and do some nudging. Running a therapeutic community, I find quite often that the greatest agent of change is the community itself. Positive peer pressure and peer-driven mechanisms many times are greater than someone standing in front of you telling what you need to do. So we tried a little bit of an end run with this. The leading cause of death among Hispanics, this is really neat. The number 2 is motor vehicle injuries. But if you look at the diseases that kill Hispanics, it's okay.
Thank you, Joe.
It's okay. They kind of go hand in hand with regular diseases affecting the regular population. But the interesting thing is that a lot of these diseases are exacerbated by drinking and drug use. The project, as I stated before, was to place a short Spanish language questionnaire, and we discussed questionnaire this morning. My word program just had a field day to put questionnaire. I kept thinking it was wrong. It says that that's right. That may or may not be right. But spell check says that that's right, so it looks okay to me. But if you look at the questionnaire that you were handed, it's real simple. It only has 20 questions. The idea of it was to put it in waiting rooms of where Hispanics go for primary care. And where do Hispanics go for primary care? Community health centers and the health department. That's where they go. And who goes? The wives, the mothers. And they sit in the lobby. And they see things all the time. But this is nice, and it's colorful, and it's short, and they pick it up, and it's in Spanish. And they look at it, and if you read the questions, they're kind of neat. It actually makes you think, gee, my husband's doing this, and my brother's doing this, and oh, gee. It's got a tear off at the bottom. They can take this number, they make the phone call, and they get some assistance. They get referred to Al-Anon and R-Anon. They get told about possible programs in their community. in their counties, where they're from, and try and work it. That was the target. It was not the user, because everyone tries the user. But the user's going to look at this, I don't have a problem. But the wife is going to look at it and say, gee, we have missed family activities because of your drinking. And gee, I have had to make excuses for you, on Friday night when my mom comes over. That's the idea of the peer pressure. The counties that I used were Mecklenburg, Buncombe, and Burke. Burke because I live there, Buncombe because I work there, and Mecklenburg because I have a little bit of history with Mecklenburg. For the fellows, the relationships that you're going to make in your fellowship are phenomenal. And I would be remiss if I didn't mention Buncombe County. The reason I was able to have total access in Buncombe County, during a change, when their health department is actually changing and some of the medical is going to Western Carolina community health centers, and they're actually moving locations and they're in total disarray. But we went to strengthen the black families last year, and the very kind folk there, when I said I was going to do Buncombe, they said, oh, call Gibby. So I did. I called Gibby Harris. She's the health department director. She welcomed me with open arms, took these. Now they're moving. She made sure that even though WIC was no longer where it normally was, and this wasn't where it was, and she made sure she got all these, put them out everywhere. When they ran out, called me, and took some more. The flip side of that is I had to sit on 2 health action committees with her. It doesn't come free. And they meet at 7:30 in the morning, and I live 50 miles away. But it's okay. It's all about the bagels. We have some community partners, and these are my positive community partners because, believe it or not, some of them were negative. Some of them really don't want to talk about this. It's the elephant in the living room. Except in this case, there was 2 elephants. The elephant in the living room that happened to be Hispanic for whatever reason, and then there was an elephant in the living room that was a Hispanic drug abuser or alcoholic. So these were not good folks to be around sometimes, but all these are good guys. I put all these are good guys. And you can't do a project like this unless you're really out speaking to people and trying to get the message across, because people have so many stereotypical ideas of what an alcoholic is and what an alcoholic isn't, and they're all Mexican, and that's not true. It's really eye-opening, and I am Hispanic, and I thought I was really one with the community, but even I learned a lot of stuff. The interpreter thing, that's a nightmare. that really, really doesn't work, particularly when you're dealing with medical issues and translators. So it's a lot of challenges. Did some presentations. I did the Hispanic Summit in Chapel Hill a few months ago. Recovery Festival in Greensboro had about 1,000 people. Outer Banks Conference just last week in Atlantic Beach in the rain. Very professional meetings and more presentation opportunities coming up. Challenges, chronic diseases, all that, but I want to get to, I saved almost the best for last. So I got to get to the numbers. This was semi-scientific, not real scientific. We didn't want to push a whole lot. I just wanted to see what would happen if these were put out there without a lot of pushing. Without, is your nose itch? That's the signal. That's the signal. Dr. Pence is doing this, and if you look at, we did 90 days before the questionnaire and 90 days afterwards. Mecklenburg was amazing, and Desmond was real good. I'd drop off the stuff and he'd have it everywhere. But that's pretty incredible. It's like a 300% increase without a whole lot of pushing. That's just the Mecklenburg County Health Department, both locations. Buncombe was pretty good, more than doubled. Burke County, again, tripled. The idea now, since we know that at least they're getting out, these are people that called. There are some things that we need to change. Moving forward, the 2 guys that answered the phone at the alcohol drug counseling, by the way, they were kind enough to print these for me and do the 800 number, Hector and Pedro. And it came out in one of our focus groups that, you know what, if we put Hector and Pedro here, call Hector, call Pedro, you might get even more buy-in. And here I thought I was worldly. But hey, just put my name on there, we'll get more calls. But now the idea is to go ahead and really push it, really put this out put this out with community and Hispanic advocates and really try and get it out. Because just by laying it on the table, we were able to get those numbers. And of course, I like this. I put this for years. It's one of Dr. Pence's favorite slides. Drug abuse and cardiovascular disease and other diseases run very similar. They follow the chronic disease concept. They're a disease of maintenance. They're not a disease of cure. And it's just like you're a drug addict or an alcoholic, you go to meetings, you go to treatment, you don't drink, you have diabetes, don't eat a candy bar. They kind of work together. And my favorite statement, President Obama said this last year, we have to treat this as a public health problem. If you have any questions or information, that's how you get hold of me.
So this is my topic area, suicide prevention in gay, lesbian, bisexual, and transgender youth. And I had originally in my first few slides the background, from the literature review. And just in the last couple of days, I said, why this topic, why this project? We didn't even need any words, do we? So we know we're losing young people frequently, and it seems to be happening, just snowballing right now. I don't know what that's about, but it's bringing this issue to the forefront, which is a real positive, I think, and so many people are getting more involved. But what I realized as I began this project 2 years ago is that there's very little data about this population of people nationally, and really no data in North Carolina. And so my goal was to collect some information from gay, lesbian, bisexual, transgender youth about their experiences while they were in high school here in North Carolina. So I wanted to just give you a little bit of background on suicide first. Most people don't know that more people die from suicide every year than from homicide. We hear about homicide in the paper more often, but far greater numbers of people, about 1,100 people die from suicide in the state every year, while about 800 die from homicide. So if you didn't know that, I think you'll find that interesting like I did. The other thing about suicide is it's one of these health disparity issues that affects whites more than people of color. So it's still true, at least as of 2007, and I don't think it's changed a great deal, that 90% of all suicide victims are identified as whites. And white males particularly are at greatest risk. But we do see rate increases among other people happening now as well. In North Carolina in 2007, 54 young people 15 to 19 years of age committed suicide. I'm sorry, that's in 2006, and the number was 50 in 2007. The numbers tend to stay about the same. There aren't any real huge jumps, although there was a four-person difference between those two. And finally, based on national rates, that would say that of the, about 15 to 16 of these each year would have been LGBT. So we think that about 30% of the people that commit suicide are probably LGBT. This is my logic model. I know you can't see it very well, probably from where you're from, but if you're in public health, you can't do too much nowadays with that logic model. In the work that I'm in now in child abuse prevention, it's the same thing. We work with states and local programs within states to create logic models for their programs. The few things I want to mention here, first of all, I want to acknowledge my mentor. I think all of us felt fantastic about the people that worked with us. But Dr. Janie Wong is the director of the LGBT Center at Duke, and she's been tremendous in helping me, meeting with her from the first day and just getting some of her thoughts and insights. All the way to now, I'm very proud to call her a friend, and we have dinner occasionally and get together, and we're on each other's Facebook pages. So I really have enjoyed getting to know her. The other thing I want to share with you is my primary activity, which I'll speak more about in just a minute, was using Palm Pilots to administer the survey. And they were administered to 18 to 24-year-olds because I was trying to avoid the parental permission issue with younger people. But I felt they were close enough to high school to still remember, of course, vividly what that experience was like. So we surveyed 18 to 24-year-olds about their experiences in high school around bullying, faculty support, feelings of sadness, and any suicidal thoughts or ideation. And then the other thing I'll share briefly from this logic model are the short-term outcomes, which are really what I have hoped to achieve through this project. The other things are a little more long-term. But obviously, to give us more information on awareness of this issue in North Carolina, specifically about North Carolina youth, more information on suicide risk among this population, more information on policies that are in our high schools, and many of you may know that the legislature finally passed a policy in the summer of 2009 which said that every school system must have a policy that addressed bullying, and it specified certain protected groups, and that was the whole controversy and issue in the General Assembly, which was really disgusting. Because it specified sexual orientation, there was such a fight. 2 years previous to it passing, it missed passing by 1 vote. And I was sitting there in the summer of 2009, it passed by 1 vote. But some of the arguments that we heard from legislators that were against this legislation still stun me to this day. It's unreal that educated people have those thoughts. So anyway, we have this policy. It said by December of 2009, every school system across the state must have a policy around bullying. By March of 2009, every school system must do some training with faculty and staff. Now, unfortunately, it wasn't very specific. So you could talk to your faculty and staff for 10 minutes and say you did training. I mean, these are some of the loopholes that are there that I think all those of us who are working in advocacy will have to continue to try to work around and work on to strengthen those things. So I wanted to mention that the new policy is a great achievement, but we do have some work to do still. I hope to share the information from my survey with legislators, with people in the Department of Public Instruction, with the Division of Public Health staff that I used to work with, and with others that I've run into along the way who are interested in hearing the results of the survey. Okay, so I'd like to tell you, spend most of the rest of the time talking about the surveys. I think that's what people will be most interested in. And I'm very excited because I just got the data from the man that was working with me at the UNC Institute of Public Health. He was able to compile my 2 data collection days and send it to me, I guess, just yesterday afternoon. So I've really been feverishly trying to put these slides together and just get a real general analysis together, and it'll take a little longer for me to go a little bit more in depth. But I wanted you to know that I spent the day at the North Carolina Pride Festival at Duke University about 2 weeks ago, and that's considered the state Pride Festival, so people come from all over. Last Saturday I was in Asheville for the Blue Ridge Pride Festival. It's a smaller festival, but still, you know, something that's grown over the years and been a great opportunity. I was able to survey 65 participants, 45 at Duke and 20 in Asheville, and any 18 to 24-year-old was invited to complete the survey. So I didn't have to ask about their sexual orientation. They could be gay, straight, bisexual, anything. If they were willing to complete it, that was fine. Okay, just to give you a little information on the 65 people, you can see that most of them were 18 to 21 years of age. And you can see what the breakdown was in terms of ethnicity and race. The interesting thing, I even went to the census site yesterday because this is actually matches up with the percentages in North Carolina. I was just absolutely amazed. In 2009, the census estimates that we had about 21.6% African American population in North Carolina. This is 20% of the people that took the survey. I couldn't believe that happened. Same with the Asian population and the other groups as well. So I was real pleased with that. Although I had no influence over it. But most of the people that took the survey, as you probably expect, were female. I think it's generally easier sometimes to, I don't want to say approach females, but often when I approached females at these festivals, they were in a group of people, whereas a male was probably with 1 female. So it was easier to get a lot of females. And this is what folks self-reported they were in terms of their sexual orientation, and 41 of the 65 reported that they considered themselves to be gay. You can see that we used a continuum of slightly gay, moderately gay. That's one of the first things that Janie Long shared with me that she's seeing at the university and in her research is that there seems to be this continuum of sexuality among young people, that we're moving away from having to be one thing or another. There's no conformity, and so people might move in and out of you know, who they are. And so most of us of our generation, we were probably one thing or another, you know. But now folks may feel a little more fluid. Like I may walk in this area a little bit and then go back to whatever I think I am. Really, it just varies widely by people. So I found that to be kind of interesting. I did have a young woman at Duke. She was taking the survey, and her male friend was looking over her shoulder, and she said, "Where's overly gay?" she said, "I'm overly gay." And the guy said, "I'm slightly bi." They were great. They were great. I just love talking to the young people and learned a lot from It was really outstanding, I have to say. Another thing that kind of amazed me is that the respondents were from 25 of the 100 counties, so they were pretty spread across the state. Most of them, of course, there was only one person from a county because we only had 65 total. But the greatest number of respondents were from Wake County, Durham, Forsyth, Buncombe, and you can see the others. And that probably makes sense based on where I was. But we had people in the East, which I was amazed. And at the Duke Festival, there were a lot of people from UNC Asheville and what's the other university in Boone? I'm drawing a blank. Appalachian had driven down, and of course young people from the East and so on. So it was just a great thing that a lot of folks were drawn in from all over. Okay, to get to some more of the meat, I guess, of the survey, Morgan, how am I? Okay. Considering your sexual orientation, what was your high school experience like in terms of feeling comfortable and a sense of belonging? So this is one of the first questions that begins to ask them about their experience. And you can see, rather surprisingly to me, that about half said they were very or mostly comfortable in high school. And about 13% said they were not comfortable, or that they were bullied and harassed, or that they hated high school. Those were all three different choices, but they added up to about 20% of the respondents. Okay, going a little further then, did you think the faculty and staff in your high school were open and supportive of gay students? And I thought the young people were far less harsh about faculty and staff than I kind of expected. But they said, 24 said they were very or mostly supportive, 13 said they were neutral, they didn't really feel them as being supportive or not either way. And then 9 said they were not supportive. So I was surprised that we didn't see more young people, feeling like faculty and staff were not supportive. High school can be a difficult time for many students. Did you have periods of sadness or feeling down when you were in high school? And the numbers were fairly high here for the top 3 answers, but I think high school's a rough time for all of us, isn't it? So that may be not too much of a shock. But 9 people said, yes, I constantly felt sad, almost all the time. I rarely remember feeling happy. So that's pretty upsetting. 11 said, yes, I felt sad fairly often, around once every 1 or 2 months. And then 26 said, yeah, sometimes I felt sad, but no more than 2 or 3 times a year. So that's a lot of the folks that responded that did feel sadness, but maybe that's normal, especially the 26. Okay, do you recall ever thinking about suicide as a solution to your problems when you were in high school? And this is I thought, validates our thinking and national numbers, but it is upsetting. 9 of 65 thought about suicide every few weeks or more. 8 thought about it every few months. 6 thought about suicide every 6 months or so. And that totals about 35% of the folks that took the survey thought about suicide somewhat regularly. And what we know from national numbers about suicide attempts and completions among GLBT young people, this really supports that. So it's a real issue that we're going to have to tackle as a nation. 16 of the 65 young people attempted suicide while in high school. So I just left that slide real simple. I think it speaks for itself, doesn't it? Yeah, 16, that's about 25% attempted. Did you ever attempt suicide because of the challenges presented by your sexual orientation? So once we'd asked about suicide, of course we wanted to know if they associated what they were experiencing with the challenges of a different sexual orientation, or was it some other reason? And you can see what we got. 4 said yes, definitely. The suicide attempt was related to my sexual orientation. 7 said yes, but there were other things going on. And then you can see 1 said no, not really. 3 said definitely not. So 70% of the 16 who attempted suicide related it to their sexual orientation to some degree. And that's as far as I've gotten in terms of being able to analyze the data. There are a lot more questions, and I'll look forward to cross-referencing some of the variables. Like on those suicide attempts, I haven't had a chance yet to look at, were those gay students or were they straight students? So I'll have to look at some of those things. But I wanted to look at some things and share with you as much as I could today. And these are some of the comments that young people made. I shouldn't say students because they all weren't students, but again, I thought they were pretty insightful, but the other thing I want to say about this is with that Palm Pilot, they enjoyed it, and it did give them some degree of privacy, because like the boy I mentioned looking over the girl's shoulder, I mean, he really had to dig in to see it, and she had to allow it, okay, because out there in the sun, you can't see somebody's stuff, I mean, answers, okay? So I want to say that because it did provide a measure of privacy. I also want to say that I thought this generation, 18 to 24, was so tech savvy that that wouldn't be anything special to them. But so many said, oh, this is cool. Oh, I love this. You know, and so I was really happy about that. But the thing I want to say about this is to this last question, to say, do you want to say more? You had to sit there, you know, yes, and punch in letter by letter. And so to me, standing out at a festival, that said a lot to me, that they were willing to take the time while their friends are standing there waiting, typing in anything. And so I was really pleased to get these extra comments from folks. People seem to be, I don't know that I had anybody said no. You know, I had people that say I'm too old, and they were complimented, but they were 29 or 30, and I thought they were 24. And I had people that went to high school out of state. I found that a lot in Asheville, that a lot of Warren Wilson students told me they were mostly out of state. So those were some of the challenges of being able to get more people. Last slide, I wanted to share the opportunities. Dr. Lisa Campbell, who I believe is on the Health and Wellness Trust Fund board, is that right?
She's one of the
faculty with
one of the consultants.
Okay, and she's worked with us at ECU when we went there, but she invited 2 of us to speak to her class in the spring, and that was a nice opportunity, and it gave me a chance to test my survey live with some students, so that was great.
We need you at Central.
Oh, well, thank you. I'd love to go. And then other organizations and educators have requested information. Some teachers that were at these festivals actually gave me their cards and said, you know, can I please get the results? Dr. Janie Long, my mentor, has invited me to speak at the Spring Sexuality Lecture Series at Duke. And then she also, on Facebook, wrote a number of people last week after we had, I don't know what number, suicide. And she said, I can't stand it anymore. We got to just stop talking about it. And I don't know if any of you know Pam Spalding, but she's a nationally known blogger. She's a lesbian African-American female. She's got nationally acclaimed attention for her blog. But she invited her. She invited just a range of people. And everybody has responded, yes, I will try to make a meeting and talk about, you know, what can we all together come up with. So I'm very excited about that. And the final thing I'd like to say that I'll be doing is continuing, of course, to analyze the data, create fact sheets for distribution. So I'd like to create some nice, attractive informational pieces to give to different audiences, and then writing a summary article with recommendations on what we think needs to occur. And Equality North Carolina, the group that was really behind passing that legislation, I've been working with them. They're working on developing trainings for schools, and so I'm anxious to get this information to them and really be a part of that as well. That's all I'll say. I've probably gone way over time, have I? Okay, I'm sorry. Okay, thank you.
I'm intrigued with those categories of gay. And I can't quite remember overly.
Like goes slightly, moderately.
Yeah. And I wonder, because you're going to analyze the difference between responses of straight people gay, I wonder of those different categories, how much of that relate to them feeling good in high school, whether they were, whatever gay or whatever gay, so that we know if you're feeling that kind of inner feelings yourself, how much does that relate to your response to whether you were comfortable in high school, whether you got support?
Whether you're comfortable saying who you are?
Saying, all of those other questions that you asked,
right.
When you start to tease them out, it'd be interesting to say of those percentages, what was the percentage of people
who were, I see what you're saying, a certain level, and then
yes.
Absolutely,
Yeah.
that's absolutely something we need to do.
Yes.
I want to see, certainly if you're straight, were their feelings about the same as those, in other categories?
And if you're gay, well, their feelings about that person who says I am.
Right.
Because, the whole question, and I'm not as an expert with it, is some people who are really biased against this keep saying it's a choice.
Yeah.
And some other people, and you don't want all of that when you start having all these categories.
That's a good point. That slightly moderately could lead to that. I think for me that might be more about experimentation, although I'm not sure it's fair to use that word based on what I'm learning about this.
But it was good. I'm learning that because that's the first time I've seen that.
Well, thank you.
Down.
Yeah.
But I enjoyed that.
Oh, great. Thank you very much.
The ones that actually attempted, when you do it again, because you do the breakdown of gender, I'd be interested to see what the gender was.
Sure, I can look at that. Yeah.
Because historically we hear, well, the females attempt more than males, but
the males are more successful. Yeah, I can look at that by gender, definitely.
I'd like to look at that.
Okay, I'll share it with you.
Good.
Okay.
Valerie, I want to bring all 4 of you back to in the discussion with the grantees. Is any of this of interest to your communities, you think? You referenced an interest. What about the rest of you? How might what the fellows have been doing relate to what you're doing? Or can you, at some future date, consider expanding your work to correlate with some of the work of the fellows? That's just the question. I see you nodding, I don't see any hands raised. Yes.
Myself, I'm very interested in working with the Northeastern Partnership. I'm from Shelburne County, I live in Northampton County. That's something, we deal with diabetes in our program. And I don't know how, I haven't really heard of this before. But I'm really interested in this. That's what I'm
Glad to hear it. You think, this is just a question because I'm from the East. Are there topics that you can't talk about yet?
mental health issues, I know.
Mental health.
And also this topic, big stigma, we're in the East, we're in the Bible Belt, and also with
Hispanics.
yes, Hispanics and the drug and alcohol use. We have alcoholics in the family, and that's a big, I'm not Hispanic, but that's a big issue for me too. Get the help out to people. Yeah, I mean, I like all of it.
Yeah, me too. But we got to make sure that there's a readiness in your communities for what we think can happen. So perhaps baby steps to get there.
Diabetes maybe first, because.
Yeah. Diabetes first.
You know what I mean?
Yeah, right. I wanted to make sure that we put that on the table before we left.
I was going to say the same, because we're already doing some things in Bertie, and I think someone from the partnership approached us about the grant, so we're already on board as a partner.
Wonderful. Wonderful. Well, it's been a long day, but I surely hope it's been a meaningful day. And we will return tomorrow for a half-day session and continue to advance the work of the Health Disparities Initiative and that of the fellowship. Thank you so much for your